Katoa. Welcome everyone to our lunchtime forum, our lunchtime webinar, and thank you for coming along on such a snowy, cold day. Many of us are working from home, and we're delighted to have Bronwyn along, Tēnā koe Bronwyn. Bronwyn Maguire is, I'm sure, will be known to many of you. She's a registered nurse and the nurse manager of the PDU, Professional Development Unit at Otago, Dunedin Hospital. And Bronwyn has just completed her master's dissertation through the University of Auckland. And we're very pleased to have her here today to be talking about that. The title of Bronwyn's dissertation is Implementing Interprofessional Education for Healthcare Professionals, Findings from an Integrated Review Master's Dissertation. And I was just chatting with Bronwyn earlier, and she was saying that having interprofessional education studied, I guess, from the perspective of a nurse is less usual than the allied team. So this is quite a novelty in that respect, and I'm sure you'll about that, Bronwyn. So tēnā koe, kia ora, thank you for joining, and Bronwyn will talk for about half an hour or so, and then if people have questions, please do put them in the chat or the Q&A, and we can later. Bronwyn, thank you.
Kia ora, Lorraine. Kia ora, everyone. As Lorraine said, I'm Bronwyn Maguire, and I'm the Practice Development Unit Nurse Manager here in Dunedin for Health New Zealand Southern. So this presentation that I'm going to do is a little bit interactive, so please get your phones out. We will be doing a Mentimeter QR code quiz shortly, so just if you prepare yourself while I talk a little bit more. So last year, I did finish off my Masters of Nursing with a dissertation that was looking at the barriers and enablers to implementing interprofessional education for healthcare professionals working in a hospital context. We do run a bit of interprofessional education here in Dunedin Hospital. We've got our Advanced Deteriorating Patient Study Day, Ka Huru Hura Kia, and there's a few other things that have come around. I think there are a few area-specific ones that have been developed as well, and there's works for a program for rehab, the rehabilitation team that is in progress at the moment, and we're aiming to make that interprofessional as well. So we will kick off into our Mentimeter. Sorry, it takes a little while for this to think. So get out your phones, and if you can scan this QR code, we'll complete these 3 quick questions together and get our heads in the space to talk about IPE. There will be a QR code on each page for the questions as well. So we'll just give another 10 seconds before we move to the next slide. Cool. So our first question: what does interprofessional education mean to you? It is meant to be a one-word answer. However, if you need a 3-word phrase, I will allow it. Just think about, what it is. Interprofessional education was quite a buzzword about 10 years ago, and it seems to have fallen off a little bit in the background. A few big national projects that were in works have fallen over in the last few years, networks being one of them. So thank you. Yeah, working and learning together, collegiality, collaborative. Yeah. All right, we'll move on to our next question because I've only got half an hour here. Our second question And this speaks to why I really value interprofessional education. And that is, have you ever seen a clinical incident caused by poor teamwork? Or lack of collaboration? It's totally confidential, so here we go. Yeah, glad to hear that there are 3 of you that haven't seen any critical incidents caused by poor teamwork. It means we might be heading in a great direction. My background, I worked in ED for many years and then moved into the resource coordinator role, and I'd say most of the incidents that I heard about happening in our hospital with patient deterioration and cardiac arrest, a lot of them started with poor collaboration or were worsened by poor interprofessional collaboration. And our final question is, how important is interprofessional collaboration for patient safety? And this is actually something that we have got some data on. So I can talk about that. I will talk about that shortly. But if you put it on there, whether it's not important or extremely important. Sorry, yeah, so everyone thinks that it's really important. So I'm probably going to be preaching to the converted here. So that's fantastic because actually you all understand that it's important, interprofessional collaboration, which interprofessional education supports developing. But that means how do we, we need to move from here, from knowing into doing. So the background. Interprofessional education, also known as IPE, is defined by the Centre of Advancement of Interprofessional Education as occasions when members of 2 or more professions learn with, from, and about each other to improve collaboration and quality of care. So IPE is not merely an educational strategy. It has measurable implications for patient safety. A 2024 systematic review and meta-analysis conducted at the University of Auckland found that interprofessional learning was associated with a 28% reduction in patient mortality. Now that's a hard fact that they've got there, and fantastic that it is a systematic review and meta-analysis. The reference is in the reference list if you're looking for it, and I'm happy to share that article with anyone who wants it. That article also talked about a 23% reduction in adverse outcomes. So despite knowing this, hospital education departments have significantly lagged the academic institutions in implementing IPE for their people. So this integrative review examined the published evidence on what helps and hinders the implementation of interprofessional education for registered health professionals in hospital settings. So why I chose this topic, as I said earlier, I've repeatedly seen how essential collaborative practice is for patient safety. And in my current role as Practice Development Unit Nurse Manager, I've had a bit of success in implementing IPE, but also encountered persistent barriers, including coordinating release time across professions, differing understandings of what IPE is, and IPE being viewed as optional rather than essential. These experiences motivated me to investigate whether the challenges I face locally are reflected in the international literature. So I chose to do an integrative review using the Whitmore and NAF's 2005 methodology. My research question was, what are the barriers and enablers to the implementation of interprofessional education for registered healthcare professionals working in the hospital setting? My data sources, the initial search I conducted in May 2025. And those data sources I used were Sinal Plus, Medline, and PsycInfo databases. I started with an initial pool of 1,100 studies. And I will show you now those interested in the room, in the data. This is my search term table and my Prisma tables. And here you can see how I went from 1,100 studies all the way down to 14 that were included. So the final studies were quality appraised using the Validated Mixed Methods Appraisal Tool, MMAT, and findings were thematically synthesized into 5 overarching themes. Here is my table of studies. You'll see the boldened ones, ones where there was direct or major findings that were relevant to my question. And there are 3 tables of those as well. So they had a range of dates. I think the oldest was in 2010, the youngest was 2022, and a range of participants, and most of the studies did actually come from Canada, but mostly Canada, and there was some Australia, US, Sweden, and Denmark and the UK. So there were 5 major findings with sub-findings. Barriers and enablers were like 2 sides of each of the coins. The first finding was workforce allocation and time commitment. This was reported in 11 out of the 14 studies, making it the most pervasive theme. Inadequate time planning was not just a logistical inconvenience, it caused program failure in some of the studies. The second finding of management commitment and support was reported in 10 out of the 14 studies. The critical distinction identified was between the rhetorical support, as in the verbal endorsement without resources, and a genuine commitment with governance, funding, and strategic alignment. The third theme found was interprofessional collaboration versus a fragmented culture. This was reported in 5 out of the 14 studies. This theme revealed a paradox. The positive culture collaborative culture particularly, can enable IPE, yet IPE is often touted as the tool that can build the culture of collaboration between professions. So it becomes this catch-22. You need one for the other and you need the other for the other. So it's not something that can't be overcome, but it is something that is noticed in the literature now. And the fourth theme of staff engagement and motivation was reported in 8 out of the 14 studies, and the interplay between the intrinsic and extrinsic motivation was nuanced and profession specific. The final theme of interprofessional communication was reported in 4 out of the 14 studies, and communication failures extended beyond the logistics, and they also reflected and reinforced deeper cultural fragmentation. So across the 14 studies in my integrative review, it became clear that implementing interprofessional education in hospitals is simply not an educational challenge. It's an organisational one. Although IPE is widely recognised as beneficial, the reality of embedding it into everyday practice is far more complex. My discussion focused on the 5 major themes that emerged from the literature and their relevance to real-world hospital contexts. I'll go into them a little bit more deeply now. The most consistent barrier across the studies was the difficulty in releasing staff for IPE. As we all know, hospitals operate under intense workload pressure, and rostering systems differ between professions, making shared release time difficult. Several of the studies highlighted short staffing as a direct barrier, including Gupta et al. 2019, who noted short staffing in the nursing workforce as a key obstacle. Protected time, when available, acted as a strong enabler. Bush et al. 2022 identified protected time as essential for successful implementation. This theme reinforces that without structural support for time allocation, even highly motivated staff cannot participate meaningfully. There was a notable gap in this section. Allied health professionals' scheduling needs were not explored in the included studies, which I found interesting because allied health professionals have a more collaborative professional culture built in, being that they are several cultures in the one under the one heading. So that is something that would be good to look for in the future. Leadership support emerged as a decisive factor for implementing IPE. So when leaders provided resources, funding, and strategic alignment, interprofessional education initiatives were far more successful. For example, Schmutz in 2022 found that strong governance structures and management support were central enablers. Conversely, when rhetorical support without action was a common barrier. Wittenberg et al. 2016 described the lack of local funding and leadership support as a major limitation. This theme shows that IPE cannot rely on goodwill alone. It requires organisational commitment that translates to practical support. There's a few practical recommendations from the evidence, and that's connecting IPE metrics to the executive KPIs so that you can increase the sustainability of your program. Also, using tools like Kirkpatrick's 4 levels of evaluation can actually help build the business case to engage leadership with your cause. Right, the third was interprofessional collaboration versus fragmented culture. Professional culture barriers were prominent across the wider literature. Hierarchy, professional identity, and mistrust between disciplines are frequently undermining collaboration. Dallenborg in 2019 highlighted a lack of trust in power dynamics as a barrier to interprofessional learning. Some studies also noted that IPE was not always considered relevant to professional goals, as reported by Goldman in 2021. On the positive side, when teams had strong cohesion and trust, IPE was easier to implement and more impactful. This theme underscores that cultural change is essential. Without addressing disciplinary silos, IPE cannot thrive. There are a few things that we can do here as well. If we can find ways to give some accreditation to training. Physicians are more likely to engage. Offering CME credits or aligning with academic institutions may reduce this resistance. Also, if you're facilitating IPE, we need to be alert to our own language and framing, whatever professional culture that we come from, and framing specifically around our perspective, because we can, if we do that, we can marginalize other voices. So, motivation, staff engagement and motivation. Motivation varied widely across the studies. Intrinsic motivation, such as wanting to improve patient care, was a strong enabler. Staff enthusiasm was noted in multiple studies, including Clay Williams, who found that staff and some management enthusiasm supported implementation. However, psychological safety was also crucial. Eccles in 2020 identified psychological safety risk as a barrier, showing that staff must feel safe to participate, especially in simulation-based IPE. This theme highlights that engagement is not just about interest, it's about creating environments where staff feel supported and safe. Finally, the final finding was about communication. Communication systems played a significant role. Fragmented communication networks made coordination difficult, while centralised systems enabled smoother implementation. Clay Williams in 2015 noted ineffective communication network as a barrier, whereas Schmutz emphasised good communication as an enabler. Strategic communication, such as clear messaging from leadership, also helped build engagement and alignment. This theme shows that communication is not just an interpersonal issue, but an organisational infrastructure issue. So there are some recommendations that I have brought from this study. Or from my review, I should say. And so firstly, for IPE designers and facilitators, it's important that you understand adult learning principles and always communicate the why, not just the what. Design the objectives that reflect the learning needs of all professional groups, not just the dominant cohort. Build psychological safety explicitly into the program design, not just as an afterthought. Use an interprofessional facilitation team that models the collaborative behaviours that are being taught, and offer varied formats, shorter sessions, simulation, case-based learning, and think about the different rosters that you're going to have to work within. For clinical leaders and managers, translate the verbal support into funded release time and governance structures, embed IPE in organisational strategy, and connect IPE outcomes to executive performance metrics. Engage the professional leaders early to prevent hostile or passive barriers to staff attendance, and consider restructuring hospital education departments to enable multi-professional or interprofessional delivery. And then for the wider New Zealand context, further New Zealand-specific primary research is urgently needed. This review found no New Zealand-focused studies meeting the inclusion criteria. Health New Zealand should consider reinstating policy mechanisms such as the clinical lead for interprofessional education and protected funding streams modelled on successful programs such as networks. Lessons from allied health, where IPE is more deeply embedded, could be systematically applied across all professional cohorts. And so this appears to be the first integrative review focused specifically on barriers and enablers to IPE for post-registration hospital-based healthcare professionals. The key limitations included that it's a single reviewer design. I didn't have a second reviewer for validation. It was restricted to English language articles, and the majority of the studies originated in Canada, limiting the direct transferability to the New Zealand context. The 14 included studies also focused predominantly on nursing and physician perspectives, leaving allied health professionals underrepresented despite their known engagement in IPE. So the key takeaway from this is IPE in hospitals requires more than just enthusiasm. It requires protected time with funding, intentional leadership structures, deliberate culture building across professional groups, and communication strategies tailored to each cohort. The biggest risk is treating IPE as a nice to have rather than a patient safety imperative. The evidence is clear: when done well, collaborative learning saves lives. So thank you, everyone. I have got 2 slides of references just because I had to include all 14 studies, but there they are. Lorraine, I can hand back to you and see if there's any questions.
Thank you, Bronwyn. So if anybody has any questions, pop them in the chat or the Q&A. And Jan Johnston is just querying, did you not find any allied health studies? You didn't find any allied health studies.
I did, and if we go back to the table, there were some that had participants that were from allied health contexts. There was actually quite a few that did still have that, but they weren't commented on specifically. Often in those studies, even though they were there, they weren't the problem, maybe, from the reading. So, yeah.
Yeah, thank you. And another question from Jules. Oh, sorry, I'll carry on with Jan's because it's related to what you've just said. And she says inclusion and exclusion criteria.
Yeah, so I'll go back up to my Prisma here, and you can see so the inclusions were pretty much all the keywords, and exclusions ended up being down here. So if it wasn't primary research, the IPE had to meet the CAPE definition, and they had to talk about barriers and enablers specifically in the results section, because you'll see if you look through the question for each of these studies, they didn't align. Some of them didn't align at all with my question at all. It's just they happened to talk about what were barriers and enablers, and so they tended to be more the indirect or minor studies that did feed in a little. Yeah.
Okay. Thanks, Bronwyn. And Jules asks, Bronwyn, what ideas do you have for Dunedin to implement better IPE?
I think that we are at least the practice development unit over here, we try to think about that when we are implementing a new program. I think that we're very lucky to have key players across the Otago site particularly. We've got people like Alice Brack and Ange Price, the physios, who really believe in this as well and will come along and help design programs. The rehab study day that is looking to start up soon, I've just had a message from someone wanting to have a chat about how we can implement that as IPE, and it's just coming to us with an idea and thinking about how we can make this work and navigate some of these things. Again, thinking about the research, one of the things that I came away with was actually implementation science, using implementation science frameworks like your Kotter's 8-step change model. are actually really good places to start for this, and actually using that change philosophy when you are designing IPE can actually be really useful, because you are communicating with stakeholders, including the leadership, and actually bringing people on board, and yeah, it aligns really nicely. So
yeah, it's a good structure, a good framework.
Yeah.
Bronwyn, I was last from Jan again. Just say thank you for this thank you so much for your very valid research. There aren't any more questions at the moment, but I have a couple, if that's all right.
Okay. Go on.
Go on. So, why Canada, do you think? Why did so many studies come from Canada?
I think they are. I think
be an answer.
I don't know why it's so much, but they are another socialized healthcare system where where I think in other areas, like because most of these aren't they? That if you think about sorry, I've got lots of people talking to me. I hope the teams aren't popping up on the screen as well. But you'll see.
They are, but that's okay. Yeah. That's right.
So
it means that you're generating interest, so that's good.
Yes. So you'll see that most of them, other than the two USA, are health systems that do have socialized medicine.
Okay. So it might be something like that.
I think there is something probably in that, and following. Yeah, I don't know. I didn't really study that specifically. So
no, that's fine. That's fine. I just thought you might have had a hunch, but somebody says that 6ATR has introduced the Calderdale framework, and HCA is carrying out PTSs that are usually carried out by OTs. This has been a stepping stone to IPE for us. So that's a comment from someone. And then the next comment links to mine. They say, would you like to do further research in this area? And that was my question. It was a research question as well. I don't know what that person's thinking of specifically, but to me, this begs a qualitative study where you ask the interprofessional groups themselves, what do they think are the enablers and the barriers?
Yeah. And I think it would be a very interesting research to do, because there was nothing out there that actually directly asked the question. It was quite difficult, and that's why I cast my net so wide to get that 1,100 studies, and then just my exclusion criteria was quite narrow. So because there is nothing that actually addresses the direct question. So I think it is important whether I would do it myself. I think there were more questions that came to my mind by the end of the study that I think I would like to go down other rabbit holes, particularly thinking about the difference between undergraduate interprofessional education and workforce interprofessional education. There is actually quite a significant difference between what they are, and I think that's fascinating for me with the educational lens, and
fair enough. And I think that might be all from everyone, Bronwyn. I don't think there are any more questions, but just to finish up, thank you very much, Ngā mihi nui. That was fantastic. And I think if you did go on to if there was any further research done, it would be really good to do it in collaboration with interprofessional researchers. Absolutely. So you're already working together on a topic that you all have some passion for. I really like the way you opened this presentation with the Mentimeter. That was fantastic. That was engaging. Great way to do it. And the other thing that struck me is when thinking and looking at interprofessional education is to be really conscious of our own framing and our own language. And sometimes that's really hard to do when you're right inside it. And I found that out when I worked in occupational therapy school for a year. I thought we had pretty shared language and everything, but quite a different, well, while we do, there were also differences, and the emphasis on occupation and other things that I hadn't considered before. So that was like going into a different culture, actually. So that's something to be really mindful of, isn't it? That was an interesting comment.
I think that speaks right to the definition of interprofessional education, though, because interprofessional education is about, it's when two or more professions come together to learn about, from, and with. And so that learning about each other's language is so important and builds that interprofessional collaboration so strongly. And so about, from, and with. So they are
and questioning each other, because sometimes you don't know that you are framing everything with your own lens until someone says, "What do you mean?" Anyway, Bronwyn, that was fantastic, and thank you so much, and congratulations on your achieving your master's this year. This webinar has been recorded. I saw there were some comments about that earlier. So Trish sends around the link of the recording at a later date, so everybody will have the opportunity to listen to Bronwyn's fine words. Kia ora. Thank you, Bronwyn. Bye, everybody.